The holidays have begun. Winter is here, and so are the respiratory viruses. Welcome to the Urgent Care Association Solution on Demand webinar brought to you by HealthTrack RX. Today we'll be discussing some interesting patient cases and the role of multiplex rapid PCR in optimizing clinical decision-making in the urgent care center during these winter months. Respiratory tract infections can be caused by viruses, bacteria, and they're more common during these winter months and can present with similar symptoms that can cause clinical confusion and make patients really difficult to diagnose and treat. I'm your moderator, Ben Favre. To work through these cases today, we're joined by two experts in molecular infectious disease diagnostics in the urgent care setting. First, we have Dr. Janie French, who is the medical science liaison at HealthTracks and a clinical microbiologist. And we also have Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville Health, most importantly, and he's also has a very important job as Chief Medical Officer at HealthTrack RX. Dr. Goldberg, as we jump into things, I'm interested to understand from a clinician's viewpoint, what do you focus on in dealing with the challenging patients that you see in the urgent care center this time of year?
Well, Ben, I'm excited to discuss these cases and cases that are occurring at this time. As an urgent care clinician, I found it helpful to apply principles of evidence-based practice, case by case by case, so that drives consistent operating by the clinician. That said, each case still has to be considered individually, and we'll show how that's so important on the cases we discussed today.
Fantastic. So let's jump into our first case. So Dr. G, our first patient here is an 88-year-old nursing home patient that presents with cough, runny nose, and nausea of 2-day duration. Recent facility transmission of COVID-19 and influenza virus. The patient has COPD and coronary atherosclerotic heart disease. No history of COVID infection. Flu illness history is unknown. No recent vaccinations, interestingly, and a temperature of 100 degrees with mild ill appearing, not short of breath. Lung exam has decreased breath rales and rhonchi. Laboratory COVID and influenza AB point of care antigen test is negative. So Dr. Goldberg, this is a complicated patient, a lot going on. Clearly you have a sense of urgency in taking care of this patient. What are you considering?
Ben, you're right. Complicated patient, a lot going on. The first thing I do is get my mindset right as I'm thinking through the information you just provided. When you engage patients above 85, and for that matter, somebody 65 and above with comorbidities, the extent of the illness they actually have might not be fully manifested in the signs and symptoms that they show in your clinic. Have to keep that in mind. We also want to consider the client's living setting, their medical history and exam findings, and any available diagnostic insights that's available in our clinic. So considering all of that to inform our medical decision-making, the care plan, and the treatment and follow-up plan.
Very good. So Dr. Goldberg, you have a great advantage today in that you get to phone a friend whenever you need. You have a clinical microbiologist and Dr. Janie French here to help us out. So
Awesome.
Janie, that makes it easy, right? We always wish we had one in our back pocket all the time. So Dr. French, how would you advise a practitioner such as Dr. Goldberg to think about the pathogens to consider and the diagnostic options for this patient?
Absolutely. Like Dr. Goldberg said, this is an elderly patient with comorbidities. Viral illness may be more severe in this patient, and there may also be additional concerns about development of pneumonia. But beyond that, you also mentioned that this patient resides in a nursing facility. And congregate living can mean that there's elevated transmission risk. So if this is a viral illness, we want to identify that because getting them on an appropriate antiviral treatment may mean that we can reduce transmission to other residents within the facility. That's something we want to be keeping in mind. Next, we want to be thinking about diagnostic techniques available. Many clinics have rapid antigen tests available for performing tests in the clinic. However, CDC recommendations state that these antigen tests for flu specifically less effective when used more than 4 days after illness onset, because at this point, influenza virus shedding decreases after this point in most people. However, this patient presented early during illness, so we're not so much concerned that the length of illness is going to impair our ability to detect infection by a rapid antigen. We want to also be thinking about what is viral circulation like within the community, as this is going to be really a major indicator of the accuracy of our rapid antigen tests. While antigen tests are effective for identifying viral illness during periods of high viral prevalence, periods of low virus circulation reduce their positive predictive value. So, for example, when influenza prevalence in the community is less than 2.5%, the rate of false positives is very high, even with a very specific test. So if an antigen test is positive during times of low influenza prevalence, like perhaps in the summer months, a PCR test should be used to confirm the diagnosis if clinical decision-making is going to be impacted by the test results. In this particular scenario, a negative antigen test might not necessarily be sensitive to completely rule out COVID or influenza infection if prevalence within their congregate living facility or within the community is overall low.
Excellent. Great insights, Janie. Dr. Goldberg, you have a wealth of knowledge there to help you in your clinical decision making. Walk us through what you're thinking in this patient and what your next steps are.
Absolutely, Ben. And as Dr. French described, thinking about the accuracy of testing, thinking about the congregate living, thinking about the different pathogens is super to have in your mind as you're walking in to evaluate the patient. So here's how I think through the case. The first, severity of illness. How sick is this patient? Now, this individual has medical comorbidities and exam findings that were described that could indicate pneumonia. The highest death rates for people with pneumonia are those above 70. Then I'm thinking about the intensity of care needs. So once I figure out what's going on, I need to assess if I can get them what they need in the congregate living setting where the patient resides. Then I ask myself, is this patient safe for outpatient treatment? I keep in mind different clinical algorithms. The IDSA has them, other groups have them, that suggest if certain features are present, person's more likely to do better with treatment in the inpatient setting. Now, in the history we got, there was no note of cough or sputum or dyspnea or pleuritic chest pain. And those are all features in the IDSA guideline that suggest this person might do better treated in the inpatient setting. So I think we're going to be okay with outpatient management. Then we want to think about medication regimen and if we're going to treat for bacterial infection. And in that case, we want to consider if the patient would be at risk for more difficult bugs like methicillin-resistant Staph aureus or Pseudomonas infection. And finally, risk to follow-up. We want to make sure we're going to be able to watch the progress of the patient's response to our intervention to confirm they're getting better.
Very good. Great insights. Thank you, Dr. Goldberg. Let's move to our first audience survey question. How do you use rapid antigen tests in your practice for respiratory testing? I use rapid antigen tests year-round. I use rapid antigen tests during respiratory season, and I never use rapid antigen tests. Wait a second here and let a few answers come in. While we're waiting for the answers to come in, Janie, quick question for you. Dr. Goldberg mentioned some of the multi-drug resistant pathogens like MRSA and Pseudomonas. I know one of your areas of expertise is polymicrobial or mixed infections. In a patient like this, what are your thoughts and concerns about those pathogens?
In general, secondary bacterial infections causing pneumonia are really going to be of concern after a viral infection. Given the length that this patient has been ill, it's probably not of major concern at this point to worry about bacterial infections. It's more likely that they're going to have a viral respiratory infection instead.
Excellent. Very good. So we have our results. Dr. Goldberg, preponderance of people are saying they use rapid antigen tests year-round. Any surprise to you there?
No, Ben, while data suggests many of our clinicians are making decisions without the opportunity of diagnostic insights at the point of care, it seems many of our listeners have point of care testing, and where I practice, we do as well. We're able to identify group A beta hemolytic strep, we'll call it strep A hereafter, influenza A and B, and COVID-19 when evaluating respiratory complaints.
Excellent. Very good. Janie, anything to add on this case before we move on?
I just would add that I don't think there's necessarily a singular right approach. We want to keep in mind the limitations of rapid antigen tests. These are going to be most effective during respiratory season for identifying a positive result. And in the summer months or outside of respiratory season, these tests are going to be more valuable for identifying negative results, as that's when the negative predictive value is going to be higher. So using that information to appropriately interpret the rapid antigen tests will improve outcomes overall.
Dr. Goldberg, one other quick question for you. JAMA recently reported a high rate of diagnostic errors for a patient very similar to this, patients with community-acquired pneumonia. Clearly, the current paradigm of no test, no culture or testing, and then using empiric therapy needs to be improved when you have that rate of diagnostic errors. What can PCR offer that may help help improve diagnostic errors for a patient with pneumonia?
That study, a European study, large study, looked at both initial evaluation in the ER and time to treatment in the hospital, gave us some interesting insights. And it basically showed how PCR appropriately applied can get a diagnosis in a time-based manner and more likely treat someone more accurately because of that. And that overall should improve outcomes. So that can be very, very powerful.
Excellent. Great insights. Thank you. A few wrap-up points. Janie, why don't you walk us through your thoughts on the wrap-up points and read them out to us real quick.
We mentioned this a few times, but the negative predictive value and the positive predictive value of rapid antigen tests is going to be dependent on community prevalence. Using resources that are publicly available, such as virus circulation patterns published by the CDC. Additionally, HealthTracks does publish positivity reports on their website available to the public. These can be a great starting point for understanding what's circulating right now in the community. And rapid diagnostics in general are going to be valuable in reducing patient anxiety, improving patient outcomes, and preventing the overuse of anti-infectives, as we know that antimicrobial resistance is of increasing concern globally. So we want to be good antibiotic stewards. Last but not least, the rapid clinically actionable PCR can be a technique that allows testing for multiple types of pathogens from a single sample. So in situations or cases like the pharyngitis patient that we just talked about, being able to test for both group A strep and respiratory viruses is not only a tool for identifying streptococcal pharyngitis that needs antibiotic treatment, but it's also a tool for identifying viruses so the patient can understand that an antibiotic might not change their outcome. These are really just different helpful points to keep in mind as you go through respiratory season.
Very good. Dr. Goldberg, one of the takeaways that kind of comes through in these cases today is the importance of speed and the ability to get accurate diagnosis in these patients and be able to make that don't treat decision as soon as possible so they can get healthier faster. What are kind of the things you look at from a clinician standpoint on when do you say, okay, I want to do that rapid PCR because I can now get answers back the next morning? When do you pull that trigger and what makes you comfortable? And when do you say, hey, I'm going to use some diagnostic stewardship here and not do a test versus do the test?
Yeah, Ben, three considerations. So in someone that's elderly, they're not going to show the signs and symptoms that necessarily affect how ill they are. So I want to get that diagnosis right and I want to get it fast. First case. The second would be in someone who I am concerned that I have to start a therapy to impact a sequela, long COVID, bad COVID, group A strep, seeding a valve, or a kidney. I want to get that right, and I want to get it done timely. Now, our cases, folks presented within a day, that was an opportunity. But if they were presenting day 3, day 4, the clock is really ticking quickly. And then finally, what I'll add is you really want to do evidence-based practice, have a method that you're using to evaluate these cases, but then look at each individual scenario and points such as where people are living. Are they going to be lost to follow-up? Are any of their health conditions out of control? And then the epidemiologic considerations that Dr. French highlighted are all important elements for decision-making.
Excellent. Thank you both. Thank you to everybody in the audience for joining us for this Urgent Care Association Solutions on Demand webinar brought to you by HealthTrack RX.